You're listening to the We Are Libertarians podcast network. Find all of our shows at wearelibertarians.com.
Episode 31, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. Thank you so much for joining me after our long 3 or 4 week break here. I had to take a little time for the family and for myself to recharge the batteries and kind of get things going again. So we're going to leap into 2019 here and begin another full season. And I'm still planning on trying to get about one episode a week. We'll kind of see how it goes, but that's still the plan for now. And so this is going to be the first time back, and we're going to be talking about death today and brain death. Is there a difference? Are they the same? We're going to try and get into that a little bit with Dr. Shewmon, who's an expert in death, and he's at a bit of the forefront of the controversy with the designation of brain death and whether that we can use that as a designation for death itself, because we don't use the designation for brain death for any other organisms outside of humans that I'm aware of. I don't think people use the brain death designation for their pets or animals out in the wild or anything else. And so what does that mean for us from an ethical standpoint, practical standpoint, and then how comfortable are we with the designation? So if you are brain dead, are you actually dead? And then if we accept the fact that brain death is a reasonable way of assigning someone a death, even though their organs and the rest of their body may be functioning properly, are we comfortable that when we make the diagnosis of brain death, that we're correct and we're accurate? And so those are the things we're going to get into today. I am going to a little bit more preface with this for the beginning of the show, simply because I did not do a good enough job during the interview of fleshing out, I guess, what I was trying to go and what we were trying to achieve at this episode. So I apologize for that, and also there was the internet went down in the middle of the show, and so there'll be a discordant question where I say I'm not quite sure what we were talking about, and it's because we lost internet for a little bit, and it was all entirely my end. And so for that, first world problems, right? I hope that by the end of the show, you'll have got a better understanding of the controversy that exists, that is, I wouldn't say brewing, but certainly has been out there for the last 10 to 15 years, maybe longer. It's kind of hard to know exactly when, but there have been some recent neurologic cases that have been a little more concerning. There's a lot of literature that you can read. There'll be a number of links at the paradox.com/031 that you can jump down the rabbit hole, and you can get lost in trying to find an answer, or I guess you'll certainly find lots of controversies as we try and better understand what death is and the ethical implications of brain death, because it obviously affects transplants. That's the most prominent one, but also, when you can comfortably remove support for someone, and legally the implications for hospitals and families and whatnot. And so these are all important things, and I think it's important to sort of figure out in our own minds what death is and whether brain death is a reasonable alternative to have, or I guess a further designation to have in addition to just having the term death. Is there a brain death, I guess, is in the sense that we are talking about not the brain itself as much as we're talking about an organism or person who no longer has brain activity. They may have, the brain still might be present, and they may still otherwise be fine in the sense their heart's still beating, their kidneys still work, and et cetera, but that their brain function is no longer present. And so is that person dead? And I think is really the real question. And so most of the time when we talk about brain death, we're talking about the person who is declared brain dead, not the actual death of a brain, because those can sometimes be different, as we'll get into some of the more nuances during the show. But I'd really like to thank Dr. Alan Shewmon, who joined me for this interview. He's an expert on this. He's, again, at the forefront of the controversy, and he is someone you can find plenty of more information, interviews. He gave a lecture that I'll reference to in the show. Again, it'll be in the show notes page, which is, I think, very well worth watching, and the further discussion on what the implications are of this case that we'll talk about with Jahai McMath. But without further ado, I'd like to thank you for joining me, and enjoy the show. Welcome. I'm with Dr. Alan Shewmon, who's a professor emeritus of pediatrics and neurology at the David Geffen School of Medicine at the UCLA in Southern California. And today we're going to be discussing brain death. And Dr. Shewmon is an expert in this, and he's had a well-published in, I guess it's probably fair to say that your definition of brain death is a bit different, or I should probably back up a little bit and say your definition of death is probably different than what is the commonly accepted. Is that fair?
No, I don't think that's fair. My definition of death is pretty much the same as Jim Burnett's definition, which is the irreversible cessation of functioning of the organism as a whole, or better put, the irreversible cessation of the organism as a whole. Okay.
And so to set the table, we'll talk briefly about the case of Jahai McMath. I'm not sure if I'm pronouncing that name correctly, yes. But she's, I think she was 9 at the time when she, from complications from a tonsillectomy, a number of course events, she became, they had problems with her airway, and she was starved for oxygen, correct?
She was 13.
And 13. Okay, so she was 13 at the time, and she suffered injury because of problems with oxygenation, and at the time she was evaluated by a neurologist at the hospital, and I believe it was in California, and they determined that she was brain dead, and her family did not agree with the diagnosis, and they took her to New Jersey, which is one of a few states that allows you to continue care for people who are on religious and conscientious reasons. Is that correct? And then from there, there's obviously a malpractice case involved, and then you went to evaluate her, or you looked at some of the video evidence from the family. And so before we go into the specific of the case, why don't you describe to us what the current concept is of brain death? Because I think most people are generally familiar with that. My audience is probably half medical professionals and half the lay public. And so why don't you go briefly into what the definition of brain death is right now, and then we'll kind of go on from there.
Well, just the term brain death is kind of unfortunate from a linguistic point of view, because it could be understood to mean either death of the brain, like necrosis of the brain as an organ, without implying anything about death of the patient, or it can mean death of the patient by virtue of neurologic criteria. So it can mean either of those two things, and it often gets blurred and leads to sloppy thinking. But if we understand it to mean the death of the patient by neurologic criteria, which is how I think most people understand it, then the idea is that total destruction of the brain or total non-function of the brain that's irreversible is the death of the patient. Now, why that should be, people have been arguing about since the whole idea was introduced in 1968 by the Harvard Committee. So some people maintain that the reason that is death of the patient is because the brain is the location of personhood, or brain function produces personhood. And so if you destroy that, then you destroy the person, so the person is dead. That is That doesn't require the whole brain to be destroyed. So that just requires irreversible loss of consciousness, essentially. And so this understanding of the rationale for brain death is often called the higher brain death concept. So another rationale that has been more the standard is that brain death is death because it involves loss of integration of the organism. So the organism is no longer a unified whole, so it's no longer an organism. So the organism has died. That is probably still the mainstream rationale for brain death. But there are many reasons to doubt that actually works as a rationale.
Right. And so if I could just summarize, I guess, real briefly, the contentions are is that the brain is seen as sort of an organizing, the integrative part. It's the sort of the supercomputer of the body, and without neurologic activity or brain function, the body is unable to sort of survive on its own, right? You're unable to breathe, you're unable to, get food, nourishment, and that if you lose the function of the brain, that the body and the organs and the cellular functions will cease to be. I mean, that's pretty much the thought of the integrative model. Is that correct with
right. Right.
Yeah. And so that was, I guess, as you were saying, from the 60s through the early 2000s, that was kind of the prominent view of the brain.
Right. Right. It was the mainstream view. And
you presented a case, which I'm sure was well known to many, of TK, which is someone who essentially was in a vegetative state for a couple decades, I believe.
He was not in a vegetative state.
Okay.
So he was brain dead. He had no brain.
And was that known ahead of time?
Was destroyed by bacterial meningitis at age 4. And MRI scans later showed that he had no brain.
Right. And so then if you're a subscriber to the integrative model, you would say that the rest of the body would be unable to function. I mean, and so what happened despite this person having absolutely no brain?
Well, what happened was he continued living as an organism.
And right, and I guess he grew and he had hormonal changes and he was able to maintain what we call homeostasis, which is just regulating your temperature and sort of your
right
biochemical.
He did grow. Most of that time he was actually at home. He wasn't even in a hospital. So he was on a ventilator. He received tube feedings and nursing care, and that was about it.
Right, and so then that obviously is not possible if the brain is truly the critical for the body's cells and organs to function properly.
Right. But it must be pointed out that TK was the most extreme such case, but there have been many cases of prolonged survival and brain death reported in the medical literature.
Right. I mean, it's sort of like if you were to, you could make a statement saying it's impossible for humans to live underwater without any sort of additional, oxygen tanks and things like that. And then you find someone who was living underwater for 2 years and were fine. Then clearly our definition cannot possibly. There's got to be something that we're missing, right? And so it'd sort of be like along the same lines, right? This would prove that it's not, although it's probably very important and crucial, as we know, our brains are very important. It's not the only, it's not 100% essential, I guess, or critical for body functions.
Right, and I think it's also useful and important conceptually to look at the more acute brain death cases, which everybody is much more familiar with, how they present in the ICU during the first day or two of brain death. And they're much more unstable than TK or these other chronic cases were. So the instability of these acute cases is why for a long time it was assumed that the brain is necessary for integrative functioning of the organism. But when you examine the details of the physiology in brain death, or the pathophysiology, you realize that acutely there are typically multi-system damage and dysfunction that explain a lot of the instability rather than merely absence of brain function. So the common cause of brain death is cardiac arrest. And that damages the brain due to lack of oxygen and blood flow, but it also damages kidneys and liver and heart itself. And same thing with massive trauma, which is another common cause of brain death. A massive trauma, like being smashed by an automobile, and that will also damage many other organs, or could damage many other organs. So you have instability from the multi-systemic damage, and yet this is ascribed only to the lack of brain function. So that's not logical.
Right. Right.
You also have a phenomenon called spinal shock. So when the brain is destroyed, then it's kind of like severing the spinal cord at the top of the cervical cord, as far as the cord functioning below. And when you sever the cord goes into what's called spinal shock below the level of injury. So in addition to all these other systemic dysfunctions, you have spinal shock, which paralyzes the autonomic nervous system. It causes intestinal ileus, hypotension, can cause cardiac arrhythmias. It causes muscle hypotension or hypotonia. So causes absence of tendon reflexes. And if these patients are supported, then over the next few weeks, spinal shock resolves. And what you see is stabilization of blood pressure and so on. So many of these instabilities spontaneously resolve because of a combination of recovery of the damaged organs, heart, kidneys, liver, etc., and recovery of spinal shock, recovery from spinal shock, I should say. And that time course parallels the time course of stabilization of chronic brain death patients. So it's not logical to ascribe all the acute instabilities to merely lack of brain function.
Right. I mean, that makes sense perfectly. So let's discuss the case of Jahai McMath, which is how I found out about you. I guess if you could just briefly talk about how you got involved, or and then your analysis and sort of the implications of what your findings were.
Well, I got involved because almost from the get-go, her case was in the news media. So So I followed that with interest, like everybody else. And after she was transferred to New Jersey and started to stabilize, after predictions that she was imminently going downhill and was going to succumb to cardiac arrest and her body would decay and everything like that, all those predictions proved wrong once she started being treated like a comatose patient rather than like a corpse. And so in New Jersey, she did stabilize like many of these chronic brain death patients. So I started to get interested in her case from the point of view of someone with an interest in chronic brain death, because I had written an article about that back in 1998 and continued to collect cases, extraordinary cases of chronic brain death. So in the spring, I approached the family and around the same time, they began to report that she was responding to commands, to simple motor commands. So at first I thought that, well, this is a family in denial.
Right.
And they're misinterpreting spinal reflexes as volitional, which does often happen with families in denial.
Mm-hmm.
And they realized that nobody was going to believe them if they didn't make videos of these responses. So they started making videos. They started to notice that Jahai tended to be responsive when her heart rate was above 80. And if it was below 80, she tended not to respond. So I thought that was a curious observation because it kind of implies that there's some inner state going on, state changes with a more aroused state and a less aroused state that's reflected in the heart rate.
Which you would not expect in someone who is comatose, for instance.
Well, you could expect it in someone comatose, but not someone brain dead.
Sure. Okay. Right. Because comatose would still respond to painful stimuli and sometimes, at least physiologically.
Yeah. Depends on what part of the brain is injured causing the coma.
Sure.
So I began receiving these videos, and the more that they sent me, the more convinced I became that, my goodness, these really are responses. First of all, the type of movements that she made were not any kind of involuntary movement described in patients with high spinal cord injury. So they're not movements known to be made by the autonomous spinal cord. And they were anatomically specific to what body part was commanded. So if they said, move your right arm, she moved her right arm. Move your left foot, she moved her left foot. So it wasn't 100% accurate, but much more than you could explain by chance. So then I became really interested in her case because if she really was responding to commands, then she wasn't permanently unconscious. So she would have to be inwardly conscious during these periods of responsiveness, which would place her outside of the category of coma and in the category of what's called minimally conscious state, which has variable levels of arousal and can have intermittent responsiveness. So that threw a monkey wrench into the whole diagnosis of brain death. Obviously, if she's intermittently responsive, then she's not dead, and neither is her brain totally destroyed.
Right.
So in September of that same year, when she was transferred, she had some studies done at Rutgers University Medical Center, including an MRI scan, which remarkably showed a lot of gross preservation of her brain structures. So in all the chronic brain death cases that I have later scans on, the brain is totally liquefied. So it's replaced by just fluids and membranes and just a jumble of tissues, calcifications. So her brain didn't look anything like that, which kind of confirmed that there was, in fact, not total destruction of her brain.
Right.
Back at the time of her misfortune. So how is it possible that she fulfilled all the diagnostic tests for brain death back then? She even had a radionuclide blood flow scan that showed no blood flow to the brain. So if there's truly no blood flow to the brain, then the brain will become totally necrosed. So what her MRI scan demonstrated was that the radionuclide scan was simply insensitive for distinguishing low blood flow from no blood flow.
Mm-hmm.
Because obviously she had some blood flow to the brain, even if it couldn't be detected.
Right.
So I think her case is important. The way it all evolved, it's important not so much for any implications about the concept of brain death, but rather for its implications about the reliability of the diagnostic criteria.
Sure. Because the criteria are a physical exam, right, with the loss of reflexes and responses to stimulus, either light or touch or what we just term noxious stimuli, right, painful, like a pinch or something like that. And then this radionuclide scan, which tracks blood cells and tracks blood flow, and essentially, clearly she has some sort of flow into her brain. But this scan showed none at that time. And so your contention, and by the evidence set forth, the only conclusion can be there's barely enough, but there's something, but it's undetectable, or at least at that time it was undetectable to that scan. And so, and then you also have to have an EEG, I believe, also. Is that also part of the criteria now? That's
well, it's optional.
Okay.
And so is the radionuclide scan optional. So the criteria are purely clinical in terms of the American Academy of Neurology criteria. And you're only required to use these ancillary tests if there's some doubt in your clinical exam, or some part of the clinical exam couldn't be accomplished for some reason.
Okay. And so what we have here is a concern that she had a clinical exam that showed that her brain had no function. She had other tests, including what is considered, I guess, the gold standard now, the radionuclide scan, that also showed that there was no function for the brain. And these are clearly...
Scan doesn't show function, it shows blood flow.
Correct, right, blood flow, which suggests that there has to be function on some level, right? If there's some blood flow.
Well, not necessarily.
Okay.
So you could, in principle, and this has also been reported, you could have a totally necrosed brain where initially there's no blood flow, but then the intracranial pressure decreases and blood flow returns to the brain, but the brain is still totally necrotic.
Sure. Okay.
So presence of blood flow doesn't imply presence of function. Although,
I see, but lack of flow would suggest no function.
Right. So I think Jahai's case is the first indirect proof of a hypothesis of the Brazilian neurologist Cicero Coimbra regarding what he called the global ischemic penumbra. So, as you know, and many of the listeners surely know, in the stroke field, when there's a stroke, there's a central core that's necrotic because it didn't get any blood flow. And around that is a kind of donut-shaped area of decreased blood flow, where the tissue is really vulnerable. It's just on the margin of becoming necrotic, but it's also salvageable. And the whole goal of stroke therapy is to save that ischemic penumbra region, because you can't do anything with the already necrotic core.
Right.
Now, with the ischemic penumbra, there is just enough blood flow to prevent necrosis, but not enough blood flow to support synaptic function. And Coimbra hypothesized that in the pathophysiology of brain death, when the blood flow is decreasing from normal to zero, it has to pass through this range of ischemic penumbra. Mathematically, it has to.
Sure.
And when it does, the entire brain will be in a situation of just enough blood flow to prevent necrosis, but not enough blood flow to allow any function. And if you examine that patient at that time, the patient would fulfill all the criteria for brain death because there's no brain function. And if an EEG, it would be flat because there's no synaptic function. But nevertheless, the brain is potentially salvageable.
Right.
Which doesn't mean that it would necessarily be salvageable back to normal, but could be prevented from going all the way to total necrosis.
Sure. And that's why you see people with strokes who recover some functions at some point after the shock, sort of, I guess, of that, those areas of the brain return to function.
Right. So I think what happened with Jahai was that she was in this global ischemic penumbra, and that's why she fulfilled the clinical criteria for brain death. Her EEGs were flat at that time, and the radionuclide scan was simply not sensitive enough to pick up this low level of flow. So I think her case is really important by emphasizing not just a theoretical possibility, but that seems actually to happen.
Right, and I think probably it's probably important to note that this is not the typical, obviously any close to a typical case of ischemia to brain in this sort of situation, right? I mean, these are extraordinary cases, but they highlight our understanding or lack of understanding of the brain function and the physiology, I suppose, of how things work.
Well, what's extraordinary about her case is that the family fought so much to keep her going and succeeded in that fight.
I think you were just talking about what Jahai's about the penumbra and what this means.
I guess what it means is that the the current diagnostic criteria cannot distinguish between global ischemic penumbra and brain death. And the fact that Jahai's case is so extraordinary and cases like it are so rare doesn't make it any less important.
Right.
The reason it's so rare is because it's rare for families to fight to have their loved one maintained indefinitely on life support after a diagnosis of brain death. So 99.9% of patients diagnosed as brain dead either have life support discontinued or they become organ donors. So the fact that instances like Jahai are so rare is not reassuring that the diagnostic criteria are valid.
I see. So in well, I guess I would say Jahai's case is different in that we have established there's some sort of brain activity. But I guess what I'm trying to get at is that we're looking at, when we look at, as physicians, we have to at some times declare death. And so what is death, right? And so one criteria that we've been using recently is that if as soon as brain function is gone, that qualifies as death, even though you can have your cellular integrity, your organs are still functioning. That's to your contention that brain death is, you can't have two deaths, right? You're either alive or you're dead for most organisms. And so you can't have, no one goes around talking about kidney death. I mean, that's just kidney failure, right? Then you go on dialysis or something like that. So what are the implications, I guess? I guess, there's a philosophical aspect to this, or a bioethical concern on death, but what are the practical implications for what we're talking about here for brain death?
Well, the obvious practical implication has to do with transplantation. If it weren't for transplantation, there would be no need to even have the concept of brain death.
And so then, and that was happening in the 60s, right? That's when the function was, or the definition was developed in trying to figure out how to maintain viable organs for someone who is, I guess you'd say, an individual who's not salvageable. I guess it'd be sort of one term.
Right. Well, in the 60s, the Harvard committee that kind of got the ball rolling in 1968 expressed concern also about overpopulating ICUs with patients with hopeless neurologic prognosis. They were also concerned about the legality of turning off ventilators at that time, and thought that, well, if the patient is already legally recognized as dead, then obviously there's no concern about turning off the ventilator. So there were other concerns back then besides transplantation. But as things have evolved, really transplantation is the only thing that depends a lot on brain death being death.
Right. And so I guess the first question would be if we then change our definition, said that we need to have, if we no longer accept brain death as a designation for death, how does that end pretty much all? I mean, outside of living related transplants, like a kidney or something, it pretty much ends the transplant process, right? Outside of, tissue and stuff.
Well, I don't think it's that radical, because since there is this ever increasing demand for organs, that even the population of diagnosed brain dead patients is insufficient to meet, other approaches such as donation after circulatory death have been perfected and continue to develop. So, of course, every patient diagnosed as brain dead would ipso facto be a candidate for donation after circulatory death.
Sure.
So it wouldn't end all transplantation if brain death was recognized as not death after all.
Do you find that most of the resistance, it comes from the transplant community to I guess looking again sort of at the definition of brain death?
Well, certainly the transplant community, but also physicians in general who want to promote the good that comes from transplantation, and they figure, well, even if these patients are not strictly speaking biologically dead, they're, quote, as good as dead, unquote. And you wouldn't be harming them by just ending their lives and making some good out of this tragedy by giving life to others. So there's a lot of that kind of consequentialist thinking that motivates a lot of people to want to maintain the status quo, let's say.
Yeah, sure. And then so the other question I guess I have is, I feel on some level there is a philosophical aspect to this, right? Because if you believe that the personhood exists within the mind, then as soon as that is gone, if you had total necrosis of your brain and brainstem, let's say, then the personhood is gone, right? And I bring this up only because there have been some headlines recently. I don't know how viable this is, but there is a surgeon claiming that he can do head transplants. I'm sure you've seen this. I guess the question is, who is that if you transplant a head? Whose body is that? Is the person who had the head that's put to the new body, or how do you feel about that?
Robert White did this with monkeys back in the 60s.
Mm-hmm.
So presumably it's theoretically possible with humans. But I don't think philosophically that proposes any challenge, because if the brain is intact, then the person goes with the brain. So who, if somebody were to transplant a head, then the new body would be a new body. It wouldn't be a new head.
Okay. I mean, I think most people would agree with that, but I was curious what your thoughts are, since you have two living organisms that would fuse I would assume, unless we use a circulatory arrest for I guess it becomes very complicated at that level.
Yeah, I mean, I don't think philosophically it would be any different from transplanting a hand or a limb. It's just a larger chunk of tissue that would be transplanted.
And so, where is this debate right now within the neurologic community? I mean, is there any thoughts to re-examine this or to reopen this, or are people just waiting until maybe another bioethics conference or something like that before they want to readdress this?
Well, I think the neurologic community is much more interested in in the diagnostic criteria aspect than the philosophical aspect. So I think the philosophical debate is much more in the bioethics community rather than the neurological community.
Makes sense. I mean, I guess, and what is your sense for the bioethicists? Is this a problem that they're seeing right now? I know you're in all these links will be online at theparadox.com/031 with Dr. Shewmon here. But your lecture you gave to the one I watched where you're discussing the case of Jahai, but there are also a couple other people at Harvard bioethics discussion. Is this something that they're dealing with right now, or is this not at the forefront for the bioethicists?
Well, I don't know whether it's at the forefront, but it certainly is a hot topic in bioethics. For a number of decades, people thought this was sort of a settled issue, but it obviously has become unsettled, and people are talking a lot more about it than they had been. So I think the bioethics community is more receptive to the philosophical and empirical challenges than the medical community is, just because physicians tend to be pragmatic, and the philosophers tend to think more about the underlying logic and coherence of the ideas.
Yeah, sure. And I imagine there's theological concerns too. I mean, well, there are arguments made theologically too, one way or the other. Is that true too?
Well, yes and no. Within the major religions, there's divided opinion about brain death. I think it's largely a philosophical and empirical issue, not a theological one.
Well, I don't want to take up more of your time, so I really appreciate the discussion today. It was very interesting. Is there anything else you'd like to add, or places people should visit to find out more about this issue?
Well, there's a vast literature about it. So once you get started on that literature, it will link to all kinds of other articles. So, almost no matter where you start there, you'll end up getting the whole spectrum of ideas.
Well, thank you so much for speaking with me today. I really appreciate it, and thank you for making it through the technical issues we had in the middle of this episode as well.
Well, you're very welcome, and thank you for